Hello, everyone. I'm Dr. Robert Stanley. Thank you for taking time on Thursday afternoon to join us for this short presentation on piezotome, the cube. And what we want to do is talk a little bit about my evolution with the product. And then I've got lots of hands-on videos to show you actual implementation, which is really what we want to get to, because that's where all the good, fun stuff is. So the first thing, we want to talk about is when we talk about piezos historically, and I've been using a piezo in some form or fashion for about a little over a decade. And historically, when people are looking to get into piezo or they want to purchase one, they kind of have it from an outside view. They have two main things that they want to know. One, they've heard that they don't cut very well, that they're not powerful enough. And then two, the second thing is oftentimes people will say that they're slow. So what we want to do today is kind of talk about the Cube, which is a new product that I was introduced into Chicago midwinter a year and a half ago. And I immediately purchased it and really have fallen in love with it. So historically, when we use a piezo, and piezo is simply the ability for a chip, when an electric current is applied to it, that chip vibrates. And when we vibrate that piece of material, when that piece of material vibrates, if we attach that to different types of tips, we can do different things with it. And what we would do, typically you would hear, okay, I'm interested in a piezo because I have been told that it cuts bone pretty well, but that it doesn't damage soft tissue. And that's the big advantage. So you say, okay, so I'm going to do a lateral sinus window. And I'm gonna get down to the Schneiderian membrane, and when I get there, I'm gonna use my piezo to very delicately remove the remaining portion of the bone without damaging the Schneiderian. And that's really the greatest thing. You say, okay, that's the great thing. But there are a few other things that you can use it for, and I will be honest with you. I've listed in this list right here that you see on the screen, I've listed my priorities of use. And the first thing that I use my piezo the most for is atraumatic extractions. What is an atraumatic extraction? An atraumatic, because people will argue, hey, every extraction is traumatic, especially for the patient sitting in the chair. But what we're talking about is when we take out a tooth and we take out a root, we'd love to leave all the surrounding architecture in place. We'd love to leave all the soft tissue in place. We'd love to leave all the hard tissue in place. And then ideally, we'd like to place an implant immediately, right at that time, at the time of extraction. And then if there's a gap, we'd like to graft that gap. And why do we want to do that? Because the literature has supported that you get the best outcome. If you can maintain the tissues, it works better than trying to regrow them later. That just makes common sense. So that is our philosophical approach to doing dentistry in our office. So the piezo allows us to use special tips, piezotomes, to slide down into the periodontal space. So if you've got a tooth in the anterior aesthetic zone and it's broken off of the gum line and you're like, how am I going to get this thing out without having to raise a full thickness flap, having to visualize the root remnant and having to potentially remove bone? The piezo works really well, and we'll show you some videos shortly on that. The second thing that we use it for, coming off of that, the second most likely thing would be sinus grafts, lateral window sinus grafts, your traditional Tatum approach or Caldwell-Luck approach, where you come from the lateral window. And we do these traditionally. We will look at the 3D scan, and if the lateral bone is thick, like say really thick and cortical, like 3 millimeters, we're going to start with a regular handpiece with a regular carbide or diamond burr, a big round burr, and do some bulk removal. But once we start to see that the bone is getting thin and starts to turn a little blue, we're going to quickly move over to our piezo. And we're going to use a different type of tip for that. And we'll show you that in a video in just a second. And we're going to remove the remaining portions. And what the idea is that when this vibrating tool touches that soft tissue, it doesn't damage it. And that works really well. Now, the third thing, if you're doing anything in implants, if you're working in the implant space at all, and I mean placing them and or restoring them, there are opportunities to remove implants. We know that there are implants that that aren't ideally placed. We know that there are implants that fail, that break. And so these implants oftentimes need to be removed and retrieved. And so for cases like that, nothing, in my opinion, works better than the piezo. I mean, nothing. We do a lot of full mouth cases here. And oftentimes when someone's ready for full mouth, we're going to take out all the remaining dentition, place 4 to 6, 7 implants, and then give them a long-term provisional in one appointment. When we do that, they oftentimes have one implant already in place. And many times that implant is not ideal. It cannot be used in the follow-up prosthodontic planning because it wasn't placed in the proper position. Typically not deep enough. Most implants are not placed apical enough. They're placed kind of at the crest of bone, which results in an implant that doesn't work for full mouth. So these have to be retrieved. So we do a lot of implant retrieval. So how do you retrieve them? Well, you know, you could get in there with a trephine and go down over the top of it, but trephines are pretty thick. The thickness of the wall of the trephine is pretty thick, and it makes a pretty big hole, a pretty big defect. So how can we remove an implant, especially if we're taking out one implant in the aesthetic zone that may have been placed too buccal, like in the lateral position, and you want to remove it, but you don't want to remove any more buccal bone, and you want to get that implant out in the least traumatic way without breaking the remaining bone. That's where the piezo comes in. Bone reductions, we don't do a lot with the bone reductions, but we'll show you some indications where you can use it for bone reductions. And then ridge augmentations, where we do ridge splits, is another opportunity. So nothing works better than the piezo when trying to do a ridge split. You could use a disc, but if anyone's gone in the mouth with a disc, you know the pucker factor goes way up when you've got that rotating blade in there that at any moment, you know, if it hits something hard and it bounces out, it could hit some soft tissue and cause some significant damage. So the piezo won't do that if it hits soft tissue, and it allows you to be very accurate at making very precise ridge cuts. So without any further ado, let's go to our first video. So here's an example of an atraumatic extraction. So we've got a lateral here broken off at the gum line, and it's just mush. It's nothing but, you know, just mush at the top. So we're using a piezo on the distal, on the palatal, and on the mesial to create some space. Then we come in with a 301 and we just elevate a little bit. We get on the root remnant with our straight forceps and we remove the root tip. And look at the little hook on the tip of this root, little hook on there. Without creating that space with the piezo, it's very possible that if we'd gone straight to the forceps, that we would have broken the root tip. And then we would have been digging. And anybody knows who's done extractions knows you don't want to break a root tip off, because when you have to dig for the root tip, it's typically near vital structures. It's either near the floor of the sinus or on top of the nerve. And you don't want to be digging down there. You can't be terribly aggressive when you're close to vital structures. So then that procedure becomes quite long. And so we don't want to do that. So the piezo allows us to do things like that. So let's just take a second and we're going to go to our overhead camera and I'll show you some of the tips that we would use on a traditional piezo atraumatic extraction like you just saw in the video there. Hold on a second, the camera went to sleep. We got to wake it up. Now, when we talk about piezos, and I told you I've been using them for about 10 years. And then about 1.5 years ago at Chicago Midwinter, I came across the Acteon product, the Cube product. And you say, well, why did you buy that? You already had one. Why did you buy that? Well, because the first product was not very powerful. And it took a long time to do what I needed it to do. And the Acteon product was touted as having more power, and I used it on some sample products. And I said, wow, this does cut faster. And we want something that cuts efficient and fast, but not dangerous. And so that's the first thing I saw. The second thing is ease of use. So we're dentists. We've got a lot of parts. We've got a lot of moving things going on. We're running a business. We're dealing with people on our team. We're dealing with our patients. We're dealing with COVID environment. A lot of stuff going on. The last thing you need to do is have to open up a manual to use one of your tools. So when you look at the front of the Cube, what you'll notice is that there's only 2 things on the front. How much power do you want and how much water do you want? It doesn't get any easier than that. You either turn up the power, turn down the power, or turn up the water or turn down the water. So it works really well. In fact, the coding on the front of the Acteon is D1 through D4. So anyone who's familiar with Mish's bone densification classification, D1 is super hard, D4 is super soft, and anywhere in between is D2 and D3. So it's very, very intuitive as you're cutting. If you're cutting on really hard bone, you just go to the D1 setting. If you're not, you come down off of that and go to D2, D3. If you have too much water, if you're drowning the patient, you just push the button and lower the water. So it works really, really well. Super easy to use. We keep it in our surgical suite. We keep it right there on the right-hand side of the suite. And we, at any moment that I go, oh, I need it, we just spike a bag and we're ready to go. So let me show you on the overhead camera here what we've got going on here. Okay. All right. So can you guys see this? Okay. You guys can see this on the, yep, good. All right.
1 second.
Hold on, not now.
Oh. All right. So hold on. We're going to go back to me talking because the battery just died on the overhead projector. So when you buy a piezo, the piezo has a handpiece, and that handpiece can take a variety of different tips. And so what I'm getting ready to show you is a couple of the different tips that we use. The tips typically come in a kit. So you'll have like an extraction kit, you'll have a sinus kit, you'll have a lateral sinus kit, a vertical crustal approach sinus kit. You have all of these different kinds of kits that you can use. I'll show you some of these tips and how I use them in just a second as soon as we get the camera going. At this point, are there any questions about what I've covered so far? Okay, good.
Hi, Doctor, I got a question. This is Jamie V. I'm a clinical rep out of Wisconsin. You said that you have used piezo for about 10 years. Can you tell us a little more about the other systems that you use and maybe some of the differences besides the ease of use with the cube?
Sure. So with the system that I had prior to this, it wasn't, I wouldn't say it was a bad system. I enjoyed it. I used it for a decade. The situation is that when you powered it up, it would ask for like a decision tree on what you were getting ready to do. And I never quite understood that. I actually talked to some of the engineers and I said, are you actually, when I say I'm in dense bone and I'm doing a bone procedure versus a perio procedure versus a prosthodontic procedure, what's going on in the background? Because I couldn't quite figure that out. I didn't know if maybe they had some fancy software that was making the tip of the electrode, the tip of the applicator move in a different manner. So you can imagine that you have a tip and that tip is vibrating up and down, or maybe it's vibrating in a figure 8 pattern, or maybe an oval pattern. I don't know, but I never got a clear answer on that. And what ended up happening is that when you powered it up, you'd have to kind of go through this matrix, decision matrix to kind of get it up and going. And so I didn't like that. It was just a little bit more convoluted than it needs to be. I just want water and power. And then the other thing is that even when that product was maxed out and we said, okay, this product's maxed out, we're using this for very, very hard, dense bone, I still didn't have the power that I would like to have had to remove the bone. So I'm moving the tip across the bone and it's not cutting fast enough. And it cut, and we used it because the benefit was still there of not damaging soft tissue, but it wasn't as fast as a clinician would like. You'd like for it to move a little bit faster. I find that the Acteon product that I currently have has solved that problem, that it is actually, it cuts fast enough. It could probably cut a little bit faster if, you know, I'm a surgeon, right? I do surgery. I want my instrument to make the cut as like a lightsaber, right? Well, most of our instruments don't. Even when you're using a burr and a 702 burr or something, you're still not cutting like a lightsaber. So we always want them a little bit faster. But I think where we're at right now, we've got a very good product in the market that's good to use. Okay, we're good to switch to the overhead? Okay, so here's a kit. This is how they come. They come in these nice aluminum, stainless steel, I think, carriers. And you flip them over, and this is an extraction kit, as you can see. And you flip it open, and it has a variety of different tips in here. Now, I call these like the samurai swords. You see this one here. Where's my zoom? I'm going to zoom in here, guys, so we get a little closer. There we go. That's pretty good. All right, are we in autofocus? We're going to go to autofocus here, guys. And this is the, if you've ever seen any of the Japanese animation movies where they have swords, this is like that Japanese animation sword, I always think. It's got the serrations on it, if you can see that on the edge there. Really nice and aggressive. And this is when I need to do a lot of cutting. And I even use this for ridge reductions. So if I'm going to go in and I've got a ridge sticking up too high, I can come in this way and I can cut across it. Is the autofocus on? Okay. So that's one, but the one that I use the most, if I go back to the kit, the one that I use the most is just going to be one like this. And this is my bread and butter. And this is the one I use the most of. It's just like a regular sword, looks like a sword. That's why I call it a sword. And the team, I just have a colloquial term for it. I'm sure it's got some number like PS52 or something like that. And you can get that from a sales rep that can help you with that. But this one right here is great. The way that I like to use this is I like to set this right down. If my finger is the tooth, I set this right up against the tooth. And then I put down a little bit of apical pressure. And then I go back and forth. Let me show you from the side. I go like this, and then I go back and forth like that. And it creates a sawing action. And then this just sinks. As I'm wiggling it, it just sinks down until I get to depth. I use a little neck here to determine how far down I've gone. And typically I go down to just to the apices of the tooth. And I acquire that data prior to the start of the surgery by looking at the CT scan. So this is my bread and butter for extractions. I use this all the time. I used it yesterday. If you tuned in for our live surgery yesterday, we did an anterior tooth, tooth number 8. We extracted it and it was broken off at the gum line, and we used this instrument. So that's on YouTube. If you want to check it out, you can find it on our YouTube channel and Stanley Institute YouTube channel. But you can see exactly how we use this. Now, remember, if you're going to use this to take out a root remnant in the aesthetic zone, you don't want to use this on the buccal. You don't want to use on the buccal. And that's because that buccal bone is really thin. That buccal bone in the literature is usually 1 millimeter or less, 1 millimeter or less. So you can imagine if you go down in the periodontal space with this piezotome on the facial, on the buccal area, and you go down in there and it's a millimeter thick, that you could actually remove, 300 microns, 200, 500 microns, half a millimeter of bone, and now you may have compromised your aesthetic outcome. So we would use this on the mesial, we would use it on the distal, and we'd use it on the palatal, but never on the facial. And in yesterday's case, because of the nature of the case, I was going between a natural tooth and an implant. I didn't even use this on the mesial or distal, I just used it on the palatal. And I was able to, once I got the forceps on the tooth, I think the tooth remnant came out in about 12 seconds. So it makes for a very, very short extraction, a very pleasant experience for the patient. So that's what we have for our extraction kit. Let's go to our next video. Okay. This one is another atraumatic extraction. So here we're taking out tooth number 9. And we're on the mesial side. And see how I'm wallering that instrument back and forth? That's what we call it here in the South, wallering. We did it on the palate, we did it on the distal, but not on the facial. And this tooth has been root canaled and it's fragile. So we just remove the crown and the buildup first. We get that out of the way. And then we just remove the remaining little remnants of the root. The tooth had been root canaled, so the tooth, when I put a little pressure on it, separated into some small pieces, and we were able to retrieve it quite readily. All right, so that's the typical atraumatic extraction. On the next video I want to show you is a sinus. So we've gone ahead and done our elevation. We've elevated the area. We've removed some of the gross volume of bone with a large round burr. And now what we're doing is we're using what I call the spoon. It looks like a little spoon instrument, and I'm just lightly painting. And this is where you can really tell the difference that the Acteon piezo has more power. Because when you're just painting like this is where, if you don't have a lot of power on your piezo, it takes forever. And you know, this is a very delicate kind of procedure. It's very, you know, you don't want to tear that Schneiderian. You're very, very delicate. So you kind of be very, very careful with it. So you want something that's powerful so you don't get aggressive and start to push hard. And then what I'm doing is I'm using a diamond piezo to clean up the edges, because I don't want any sharp bony edges around the edge of my window that would inadvertently cause a tear in the Schneiderian. So I'm cleaning up the little edges right here with the diamond. And this isn't like something that I would use to, I wouldn't use this to start the osteotomy when I have thick bone. If I have thin bone, I would absolutely use this to start the osteotomy. So that's a sinus. Let's do another sinus. This is a sinus, lateral window sinus graft. So we start with our 15, we do a trapezoidal wide-based elevation, full thickness. I like to make my releasing incision on the distal line angle of the tooth, 2 teeth in front of my window. And that way, if there's any sort of clefting in the attached gingiva, that clefting will be on the back side of the eminence of the tooth and less likely to show in the patient's smile. So once we do our elevation, then we're going to verify our position for our window. And like I said, I'm starting off here with a large round diamond burr, and I'm just removing just a bulk gross amount of the material. And then I go to the spoon. And then I just drag that lightly across the window until I see that I've removed the bone, and it's pretty clear as day when you get down to the Schneiderian that you're down. I have these little hand instruments. I call them the mushrooms. We have one in the kit here. I'll show you in a second. It's called the trumpet, which is like the reverse of the mushroom. And you can use those to help start and initiate your lateral window. And here's one of the diamonds going in and cleaning up any sharp edges on any burrs that could be around the edge of your window. And then we start the elevation with our normal elevation curette staying on the floor of the sinus and elevating. We like to, in my practice, what we like to do is we like to always use Picos recovery, or not recovery, but a perforation technique. So we're always going to put some cross-linked collagen membrane on the roof of the graft. These grafts, these lateral windows, as you know, if you're doing them, you get a lot of tears. Literature varies in the numbers, but quite often you'll have a tear. And even if you have a micro tear and you don't know it, you want to be prepared for it. So we go ahead and put a roof up there. I'm holding that roof in place with the cross-linked collagen with my Minnesota right now. I've kind of got it pinned on the facial, on the buccal aspect of the bone. And then we're grafting. And once we're done grafting with our minerals, our mineralized cortical cancellous graft from BioHorizons, we cover that with some PRF, and then we close all up. And makes for a very, very nice procedure. So let me show you some of the instruments on our sinus kit. So here is our sinus kit. And Siri, if we have any questions that are coming in, you just go ahead and read them out to me. All right, so here's our sinus lift kit. So once again, it comes in this nice carrier that keeps them all together in one location, and then this is your kit. So you can see this is my bread and butter right here. This is what I call the spoon. Why do I call it the spoon? Because it looks like a spoon, right? It has a bevel to it, right on the very tip there. And I don't know if you can make that out at home, but right on the tip here, there is a bevel to that right here. And that's the working edge of the product. I use that little bevel edge to make the actual scraping action. So yeah, I think we're out of range there, right there. That's probably as close to you. See how there's a little bevel right there on the tip? This edge here, not this edge on this side, but this edge on that side, that's the sharp edge. That's the side that I like to use, and I do it in a dragging action. So I would come into my location, I would touch and I would drag across, just like that, and does a great job. Once we get our window created, you can use a variety of these diamond type tips to smooth up the window, smooth up the edges, and these work really well. And then from there, you can use the trumpet. So this can go inside your window, and then what happens is the shank of the burr here acts like a ball bearing, and it rides around your window. So you go into the window, and then you ride around the window where this shank is touching the edge of the bone, and then this is pushing and starting your elevation, and that works really well. So the opposite of this, and I have the opposite of this in hand instruments that I call mushrooms. They look just like this, but instead of being a trumpet, they have like a mushroom head on there, and they do the same thing. They help me start my Schneiderian lift. So that is an example of our surgical kit for sinuses. Now, I want to go to the next video. And on the next video, what I want to do is I want to show you how we use these for implant removal. Because this is, I'm telling you, when people see this, if you're dealing with implants and you ever come across an implant that needs to be removed, you're thinking, I'm going to send that to somebody else. But if you've got one of these tools, you're going to start saying, I'm going to retrieve that myself. So here's an example. We're doing a full mouth case, so we're taking out all the teeth. We're going to be leveling the bones shortly. So I'm not too worried about the crestal condition, but see the way I'm wiggling the instrument back and forth. And I'm doing that on both sides, on the palatal side, but not on the buccal, even though we're going to be reducing this bone by a couple millimeters after we get this out. So here's a good, clean example of how we're going to get this implant out. Now, when I'm doing this, I'm not spending a lot of time trying to remove bone 360 degrees around the implant, because as you can see, I'm going to get on this with a pair of Ash forceps here, and I just rotate a little bit. And even though I have a bone to implant contact, and let's say we started off with 100% bone to implant contact. Well, when I remove the bone on the mesial, the distal, and the palatal, and I haven't touched the facial, and I haven't touched a couple of spots in between, the bone to implant contact volume, the surface area, is probably down to maybe say, let's just say 25, 30%. Well, at that point, there's such little bone to implant contact that with just a little bit of rotation or torsional force, rotating the implant, it just breaks free. There's not enough implant contact area to maintain that contact, and it just breaks free. And this is how we do almost every one of our extractions when we're removing implants. And that's the same sword that I showed you for the tooth extraction. That's why that's my favorite instrument. I use that particular tip more than any other tip. Okay. Let's go to another video. So here we have another implant in the anterior, another full mouth case where we've got an anterior implant alone by itself that needs to be extracted, and it's integrated. It's 100% integrated. We have 100% bone implant contact. If I tried to just get on that with an Ash forceps initially and try to rotate it, there's a good chance I would resect a large portion of the premaxilla. I don't want to do that. So just a little bit of rotational force, torsional force. Why? I keep saying that because it puts the bone and the implant in shear, and bone is weakest in shear. Recall that bone is weakest in shear. So once we shear it loose, boom, it's done. Implant retrieval in 15 seconds. And that's how we do that. Next case I want to show you is a bone reduction case. So here's a case where we've got an in sequence fully guided case. The bone reduction guide is in place. All of the bone that you see sticking up above the plastic needs to be removed. So what I'm doing is I'm coming in with that samurai sword with the teeth. It looks like what's the shark with the shark head? What's it called? Sawtooth, a sawtooth shark. It looks like a sawtooth shark's nose. And I come in horizontally here and I just do the same kind of action where I'm wallering it back and forth, and it's just coming across and it's making a nice horizontal cut. And here's a good example to see about how fast you can expect a piezo to work on bone, because you got a good clear view here. And I think that this this works really, really well on bone. Not nearly as slow as the old days. I would never even consider doing a ridge reduction with the old piezo. It was way too slow for that. And so with the bone reduction, I was using the samurai sword that I showed you earlier. And now let me show you the last one here. Oops, did I go too far? Oh, that was it, right?
Yeah, that was awesome.
Oh yeah, that was the last one. So let's go to the overhead real quick. I want to show them one more thing here. So here is the handheld motor itself. This is the part you hold. The irrigation tube fits on here. And I just want to show you, let me grab my favorite tool here. So inside the tip, it's threaded. So right in here, it's threaded. And in the end of the tool, there's a shank that it threads onto. So you simply put this on and tighten it up. And then once you get it tight, there's a little wrench that you can use that goes over it and just give it a little tightness. And now it's nice and tight. And that's it. And you hold this instrument. And remember, when you're going down between teeth, you're going to go in this action here. This, I call it wallering, because I've been in the South for a while and they call it wallering it. Waller out the hole. That's what they say down here. So you do like this, and then you go on the distal, and you do like that. And we're just sliding right down into the periodontal space, and gives you a nice little clear part. How much pressure do I apply to go apical? Not much. Just firm. You'll get a sense for that. You don't want to push hard. You want to let the tool do the work. You don't want to push hard. Just a little bit of pressure. Let it follow the path of periodontal ligaments, and before you know it, it'll be seated about this far. And when the shank right here is at the free gingival margin, I'm about 10 millimeters below the surface, and that's going to get me to the apex of the tooth. And remember, stay off the facial. So for tooth removal and implant removal, this is the way to go. And I wouldn't dare think about doing a lateral window sinus graft without one of these. They do make kits for a couple other things that I don't use it a lot for. So the intralift is a crestal approach, okay? So these instruments are designed to be used for a crestal sinus approach. Now, why don't I use these a lot? Well, it's not because the instruments don't work. I don't use these a lot because the technology and the implants have evolved. And what do I mean by that? Well, we now have 6.5 millimeter long implants. So sometimes instead of doing a lift, we can go with ultra wide. BioHorizons just came out last year with their ultra wide implants. You can go with a shorter implant that's very large in diameter. And what that does is that increases your surface area of the implant to the bone, which is a risk reduction protocol. And by doing that, I can maybe avoid having to give the person the sinus graft. So when we do bumps, what are bumps usually used for? Bumps, typically, a good common sense guideline is a bump just buys you a couple of millimeters. You wouldn't want to say, oh, Mrs. Smith, your subantral space is 5 millimeters, so we're going to do a 7 millimeter bump so we can get a 10.5 millimeter implant in. It doesn't make a whole lot of sense if you want to try to grow that much bone. You're more likely inclined to do a lateral window. So a bump is more like, hey, Mrs. Smith, you've got 9 millimeters of bone. I'd like to do a 10.5 millimeter. I'd like to grow 2 or 3 millimeters. I'd like to do a sinus lift through a crestal approach. That's where this kit can come in play, and this works really well. So if you're inclined to do that, then the kit's available to you. And then the last thing is lateral sinus grafts. I mean, sorry, not lateral sinus grafts, ridge splitting, okay? Now with ridge splitting, they have this lovely kit here, and it's got these great instruments because these instruments have depth cuts on them. So they have the lines giving you the indications for how far down you've gone when you're making your cuts, and this little wedge-like device here. So these are great for ridge splitting. And I don't do a lot of ridge splitting for the exact same reason that I just said I don't do a lot of crestal approaches, and that's the technology is evolved. And what I mean by that is we have gotten so good at doing grafting, veneer grafting, even in the posterior mandible, which is one of the hardest places to grow bone. But we've gotten so good with techniques over the last few years with being able to grow bone laterally. Usually you don't have it, you know, when you do a ridge split, what do you have? You have a buccal defect, right? A width defect from buccal to lingual. You have a width defect in the avillus. And what you're doing is you're splitting that knife edge ridge and then you're expanding it. So if you have ample height, but not volume and width, if you can do a veneer graft, then a veneer graft, and you can do it predictably, then maybe that's the approach you go. If, you know, and in our hands, we do really well with that. So I don't use these ridge split instruments very often because I just don't do a lot of those. But if you're doing a lot of those, then this is the way to go. Because look at the armamentarium you have here. You've got long, skinny ones. You've got short, fat, wide ones that actually do a little bit of, as you're applying pressure, this is actually going to start your ridge splitting for you versus the initiating of the ridge split with something like this, very thin. So that pretty much covers this. Let me take the, can you back the projector out just a little bit, Siri? And I want to see if I can put the cube into play here so you guys can see it.
Are you concerned about the tip hitting the implant when you remove it?
Yeah, okay, I'll answer that. So here's the front of the box. I don't know if you guys can see, it's relatively light. It maybe weighs a little bit more than a toaster. It's about the size of a toaster. It sits in there, but this is the front. Look how clean it is. It's very easy to wipe down. Here, it's not powered on, but when you power it on, it has backlit LEDs, and you can faintly make out D1 down to D4. And over here you have plus and minus for your water volume, and that's it. What a lovely, easy interface to work with. It's not complicated. And like I said, in our offices, we have so much going on. It's nice to have a product that's this easy to use. Okay, so that's it. So the question is, are you worried about the implant, touching the implant when you're using the tip? No, I'm not. If this hits the implant during the extraction, it's possible that I might damage my tip. I don't care about the implant. I'm going to be sending it back to the manufacturer anyways. So I don't care about that, but the tip might be damaged. So the worst case scenario, I might damage my tip. So I'm prepared to do that for the sake of getting the implant out and saving as much bone for the patient as possible. So that's my perspective on that. But that's a good question. You can damage a tip going up against a metal object like that. Any other questions?
None in the chat.
So guys, this last slide that I have up here has got my contact information. If at any point you have any questions, feel free to reach out to me. I'd be happy to talk to you. And if there aren't any other questions, we'll go ahead and wrap it up.
Just a quick one, Dr. Stanley. I know you mentioned the new Fat Boy, the molar replacement from BioHorizons. Are you finding, even before COVID, are you finding that you're doing more atraumatic molar extractions with immediate molar replacements?
Even without COVID, before or after COVID, it hasn't changed for me. I do probably 90–95% of my implant placements are immediate extraction and placements. Almost all of them. And I published a paper in February called the 5-Thread Guideline. It was published in the Journal of Oral Implantology, JOI. And unfortunately, no one read it because it came out right when COVID hit. So it got no press. But I'll let you know that it's free. I paid for everyone to have free access to it. So if you Google it, it'll pop right up and you can actually take a look at it. But it is a guideline that I applied mechanical engineering principles to how to predict primary stability with implants in fresh extraction sites, which once people realize, whoa, that's really important, because when you're looking at your 2-dimensional radiograph and you're saying, you've got to give Mrs. Smith an answer as to whether or not you can take that out and place an implant that day, or you need to take it out and graft it and wait. And so the paper goes into the rationale for the 5-thread guideline, which determines whether or not I'm going to be successful or not. And we use this 5-thread guideline on every single patient that we see. We use it on every single one to determine our probability of success. And what we've been doing since we published the paper is we've been tracking it. So we've got a matrix, we've got a spreadsheet, and we're saying, okay, do we think that this patient has a high likelihood of success for extraction and immediate placement? And if the answer is yes, we proceed with a guided surgery. We remove the tooth, we place the implant. And honestly, I'll give you a little heads up. We've been 100% successful so far. Like every single case that we've said, we think we can get it in, we can get it in. In fact, we've only had 2 cases where we looked at the case and planned it and said, the risk factors are too high. According to the 5-thread guideline, we are not going to do that. We're going to extract the tooth and we're going to graft the site, and we'll do a more traditional approach where we let it heal and come back and place the implant later. So we're using the 5-thread rule a lot. And what I use these implants for is I use these new short and wide implants to give me more flexibility in my decision making. And of course, everything that goes into these decisions is a little bit more complex than just, can I get the implant to fit? Because what you want to do is you want to take into account patient risk factors. So if you have somebody who has, let's say, severe attrition all the way across their arch, so you know they're having some sort of parafunction, this would not be someone that you might want to put a short implant on, even though you could get it in. Because with short implants, what they don't do well is they don't handle off-axis loads well because they're short. So the moment arm is short. And if the moment arm is short, if you put a little leverage on it, like an off-axis load, an excursive force, a prematurity, depending on how you want to call it, you put that on your crown, and that crown transfers that energy down to the implant. If you've chosen a short implant on a tooth where you have high excursive force, it's going to fail, and you're going to have a failure. So we're using them a lot, but we're also making sure that we take into consideration the bigger picture to make sure that they are in the best interest for the patient.
How would you approach an endo-treated tooth extraction in regards to power setting on the cube?
Okay, so the question is that you're working on an endodontically treated tooth, you're trying to take this out atraumatically, what's your power setting? And what I do is I have the water is typically set at about 60% of max. That seems to be about right for me. And I don't have to vary that. I might go up or down just a little bit, but 60 seems to be a good number for me for the water. And for the power, I start with the D2 setting, okay? The D2 setting. That way, I'm above 50%, 50% would be that D3, D2 region. I'm in D2, so I'm at like say 75% of max power. I'm not at 100%. I don't want to start off at 100% if I don't need it. If you have too much, you can damage things, right? If you go too hard, too fast, you can damage things. So I start off typically with that at the D2 setting. And then I do that Waller effect where I just let the instrument, I find a purchase where it sits right into the periodontal space, and you can kind of feel it. You just let it sit there. And then once you get in that space, a rocking motion with your hand back and forth with light apical pressure. Be patient. The first couple of times that you rock your hand, you're not actually trying to get it to seat. You're trying to just get it to create a good starting point. Once it starts the starting point, that's when it will, all by itself, will really start to go apical for you. And you don't have to apply a lot of pressure. And for these root canal teeth, this is the best thing in the world. For years, we go to dental conference meetings, and they would present, the whole day would be atraumatic extractions. And remember this thing that the Germans made, it looked like a wishbone with a pulley system. And you would drill a hole into the center of the tooth, and you put a lag bolt into the tooth, and you connect that lag bolt to this pulley system. And then the pulley system would rest on the occlusal plane, and then you would crank that pulley tight and say, Mrs. Smith, I'll see you in 15 minutes. I'm going to go get a coffee. And you go get a coffee, and she's sitting there with this pulley system pulling on the tooth. You come back, and then you would crank it again, say, Miss Smith, I'm going to go get a cookie. And you go back, and then 30 minutes later, finally, the tooth pops out of the socket, and you go, atraumatic extraction. That's not a great experience for the patient, right? It's not a great experience. And quite honestly, it's not a great use of your time as a dentist. These atraumatic extractions that I do, you can look to the case that I just mentioned earlier that we posted. When we posted it to YouTube, we posted the full video. It's unedited. So you can actually scroll to the part where we use the piezo, and you can see how fast I use the piezo, and you can see how fast this root canaled broken off at the gum line, tooth number 8 comes out. And this is in real time. I'm not making this up. That's a typical amount of time necessary to remove an anterior, root tip. You can use this for posterior root tips as well. It's just that typically you're more interested in the aesthetic zone, being very, very cautious without losing any soft tissue or bony support, because you want to maintain that. So I keep mentioning anterior, but it works really, really well for that. And regardless of whether you're taking out an ankylosed tooth, internal resorption, or an implant in the aesthetic zone, I don't know of a better instrument currently in the market than this piezo. It just does its job. That's what I love it for. Other people in their practice and the way they use things, you might be doing crustal sinus approaches and you might be thinking that this is the best thing in the world. But in our office, the way that I presented them or the way that we use them in terms of the number of procedures that we do. Any other questions?
Bob, let me just say that there is a learning curve with this machine.
Hey, Bob.
I know when I first put it in, I burned 2 tips, just figuring out which the power is and how much water there is to do and everything like that. I'm still learning, but there is a curve. There is a learning curve. You have to have you have to do the experience.
What Bob has been to some of our courses. So Bob's gotten one of the Acteon cubes and he's using it and he's saying, hey, there's a learning curve. And what I would encourage you to do is take a class and do a hands-on with somebody, like an over-the-shoulder opportunity to use the product for at least one time to kind of get a feel for it. So one of the ways to prevent damaging the tip or overheating something by using too much power is always start off on the lower settings. You can't go wrong starting off on the lower setting, and you go into the mouth and you try it, it doesn't do anything. If it's too low, it's not moving, you're like, it's too low, and you turn it up one setting. So never, ever, as a rule of thumb, never, ever go in at 100% water and 100% power. That doesn't make any sense.
I learned that.
Yeah.
I should have taken this before I started.
Well, now you know, Bob. Thank you for sharing.
Okay. I have another question for you.
Sure.
How did you get your sheet of the PRF so neat?
You know what? That particular sheet has to be the neatest sheet of PRF I've ever created.
Yeah, I want to know how you did it.
I don't know how, because normally your PRF, when you put it in the press, it comes out and it looks like it kind of looks oval-like and looks squished. That one came out, it looked like it literally came out of a package. It looks so pretty.
Yeah, I know. I was saying.
Thanks for noticing, Bob. I appreciate that. I wonder if anyone else noticed that PRF looks so good.
Chip also said in the chat, the good thing is that they have recommended power and water levels for each chip to help with that one.
Yep. So just to reiterate, one of the Acteon guys said there are recommended settings for each one of the tips in the manual. So if you read the manual, which if you're a dentist, you don't read manuals, I know. Mm-hmm. So as a good rule of thumb, start with the lower power, the lower water, and if it's not enough, turn it up. Turn it up. But never start at the high end and then back down. That doesn't make sense. Any other questions? Okay, guys.
Thanks again.
Oh, it's my pleasure, guys. I hope you guys have a great weekend. Stay safe. And like I said, hit me up on any of these social media outlets if you have any questions. And check out that YouTube video from yesterday if you want to see the Acteon in real time with no edits. And we will be editing that video and putting that out shortly as well, so that if your time is valuable, we'll cut out all the dead space and all you'll see are the highlights. So look for that as well.
It already was so quick. It was like
Yeah.
It was fast. It was great. Thank you so much, Dr. Stanley. I appreciate it. And on behalf of Acteon, we thank you for this time. I know it was super educational. We will be recording this. Well, I have recorded today's webinar, so we'll make that available to everyone as well as soon as I get the link.
All right, great.
Thank you, Rob.
Okay, take care, Bob.
Thank you.
Bye-bye, guys.